LAD. This is the prox LAD. You know that it tapers to the distal LAD. Distal is usually always smaller than proximal, right? The only vessel that usually distal and proximal are almost the same size is the RCA. The RCA, if usually the distal RCA, I'm not talking about the bifurcation, but proximal to the bifurcation, if the RCA is a 4-5 vessel distally, proximally it should be 4-8. There's no big difference. But the LAD, there is a tapering, or when you go from distal to proximal, it becomes big because of all the branches coming in. This is why we talked about the process of remodeling. When this is my distal, this is my proximal. And suddenly, for example, I'm looking at this location, not far from the distal. Normally, this should be bigger than my distal, right? Now, if remodeling is, I'm always comparing with a reference. If this that's supposed to be in front of my distal is smaller than my distal, we call it negative remodeling. So if I'm comparing with my distal reference that's supposed to be smaller, and I'm smaller than my distal reference, I call it negative remodeling. And what is negative remodeling? Negative remodeling is when my vessel is smaller than distally, but usually, but not 100%, usually it's normal and smaller. Why? Because there is fibrous tissue around it, there is scar tissue. So the vessel, if you put a stent there, it doesn't expand a lot. The goal is not to go high in the pressure because you can perforate. If I have a lesion and there is negative remodeling in part of the lesion, how do I make my sizing? I will still take my distal reference. Let's say my distal reference is 3.0. I will take, let's say, a 3.0 stent, a 2.5 stent. But at the negative remodeling part, I wouldn't go too high because it doesn't expand and you can perforate very easily. Now, what is positive remodeling? My proximal reference should be the biggest. And I'm just distal to my proximal reference and I'm bigger than my proximal reference. That's positive remodeling. And why does it happen? Positive remodeling, the vessel is always diseased at that location. And what happened is the vessel, to compensate from the disease, it starts getting bigger. But the problem is the lumen is the same size. So in positive remodeling, you have, let's say the vessel, the proximal part is 4.0, but just distal to the proximal part, my vessel is 5.0. So because the vessel is thinking, I have disease, let me get bigger, but my lumen is the same. So positive remodeling, the vessel is always diseased. But when you put a stent, don't try to occupy the maximum. If you get a decent lumen around 8, 9, you don't have to push more the plaque because the plaque will never disappear, okay? Now, we talked about, how do you call it? The qualitative with the plaque morphology, the remodeling, and the landmark. What are you looking for? What will make you make a decision to do a PCI is the minimum lumen area, or sometimes they call it a cross-sectional area. I always hear this question, is there a cutoff? The only cutoff we use is for the left main. Our cutoff is 6. Anything less than 6, I'm not saying do a PCI, because if you're dealing with a lady that has a small body habitus, if I don't have 6 and my left main MLA is 5.8, 5.5 because she's small, it's not 6, but you know, in case of doubt, I do physiology, okay? What are the cutoffs for the LAD, the CERC, and the RCA? In general, with all the studies, they say 5.5. Anything below is usually, like I say, in doubt, do physiology, anything above. But again, you have to take into account who you're dealing with. All patients are different. And the other thing that you have to take into account, if you're dealing with a small vessel, of course you won't think about 5.5. If it's a small vessel, you compare the location of the disease with distally, the distal reference. That will show you how big. But 5.5 is on average for all the vessels. But again, you have to remember if you're prox LED, mid LED, prox RCA, or circ, okay?
That is a cutoff after stinting, right? 5.5.